Welcome to Chronic Health Conditions Training, what school staff need to know. Brought to you by your friends at McGill School Nurse Supplies. Imagine a classroom filled with bright, eager young faces. Now, picture this. Out of every 5 students, 2 are battling at least one chronic health condition. That's over 14 million school-aged children across the country. Even more alarming, nearly half of these kids are grappling with conditions that are moderate to severe, impacting their ability to learn, play, and simply be kids. In this training video, we will be exploring the essential knowledge regarding asthma, allergies, diabetes, and seizures, the most prevalent chronic conditions found among students. It is crucial for you, as school staff, to understand how to meet students' needs, identify symptoms, and take appropriate action when a student exhibits signs of a health issue or emergency related to any of these conditions. While this training will provide a general overview of each of the 4 chronic conditions, it's important to remember that students with the same health conditions may not exhibit the exact same symptoms or have similar reactions or action plans. We'll provide the opportunity to pause now to let your school health professional advise how and where student health conditions and specific care plans are shared at your school. The first chronic condition we will be reviewing is asthma. The goal is for all school staff to be able to recognize when a student may be experiencing an asthma attack, where to find their asthma action plan and how to implement it, and finally, how to correctly support students using an inhaler. Asthma is a chronic lung disease that causes changes in the airways of the lungs, namely inflammation and narrowing that can make it difficult to breathe. While there is no cure for asthma, it can be effectively managed with supportive treatments and care, but it can be very serious and even life-threatening. Asthma is the leading chronic illness among children and adolescents in the United States, affecting 1 in every 10 students, and is also one of the leading causes of school absenteeism. By working together to support students with asthma, we can help them to have equally good school attendance, keep them safe and ready to learn. An asthma attack, also called a flare-up or exacerbation, occurs when an asthma trigger causes inflammation and swelling in the lungs and airway. Common triggers include physical activity including PE and recess, viruses or other illness, seasonal or environmental allergies, strong smells like perfumes or cleaning products, and even emotions such as laughing, crying, or feeling anxious. Each student's asthma can look different. However, there are some common symptoms that are important to look for when a student is experiencing an asthma attack. These include difficulty breathing, a wheezing sound on exhalation, complaints of tightness in the chest, frequent, persistent coughing, and fast, shallow breathing. If not treated appropriately, an asthma attack can be a life-threatening emergency. So what is the appropriate treatment for a student exhibiting asthma symptoms? First, it's important to remain calm, stay with the student, and, if possible, remove the trigger. For instance, if the student is running in PE, have them stop and sit. What to do next can be found on the student's asthma action plan. Action plans may look different, but they all contain information on the student, asthma triggers specific to that student, and treatment protocols, as prescribed by their healthcare provider. Let's take a closer look. The first section of most asthma action plans contains information on the student, their known triggers, and prescribed medications. There are 2 general types of asthma medications. The first kind are long-term controlled medications, typically taken at home and used to control chronic asthma symptoms and prevent asthma attacks. The second type are quick relief or rescue medications, taken as needed for rapid, short-term relief of symptoms and used to prevent or treat an asthma attack. The next section of almost every asthma action plan is divided into 3 different zones. The first zone is the green zone. When kids with asthma are in the green zone, it means they are not experiencing any asthma symptoms. The green zone provides guidance on how to best support your students, including the necessary steps to ensure their full participation in activities. The second zone is the yellow zone. When kids with asthma are in the yellow zone, they are experiencing mild symptoms including chest tightness, coughing, or wheezing. They may be able to do most activities but not all, due to their symptoms. The yellow zone provides guidance on how to treat their symptoms, including what medication to take, how much to take, how often, and what to do if symptoms do or do not improve. The third zone on asthma action plans is the red zone. When kids with asthma are in the red zone, they are experiencing severe symptoms and it is a medical emergency. The red zone provides guidance for emergency response, including what medications to give, how much, and how often, as well as instructions for calling 911. When an action plan indicates an inhaler needs to be used, it is important to understand how to correctly use one. This involves several steps. First is preparing the medication. Second is making sure the student is ready and positioned properly. The third step is dispensing the medication correctly. And once those steps are complete, referring back to the action plan for what to do next. Let's go over each step in detail. First, preparing the medication. The most common type of inhaler used for administering quick relief or rescue asthma medications is a metered dose inhaler, or MDI. With most inhalers, medicine is released by pushing the canister into the boot, but some types of metered dose inhalers release medicine automatically when the student inhales. Students may use MDIs one of three ways: alone, with a valved holding chamber, also called a spacer, or with a spacer and a mask attached. When a metered dose inhaler hasn't been used for a while, it is recommended to prime the inhaler before using to ensure the appropriate dose of medication is dispensed. While priming instructions may differ based on what MDI is being used, in general, priming involves shaking the inhaler for 5 to 10 seconds, and then spraying it in the air facing away from you anywhere from 2 to 4 times. Next, preparing the student. Before using their inhaler, students should be sitting or standing up straight. The student should then exhale completely, inhale the medication, hold for about 10 seconds, then exhale their breath, and resume breathing normally. Let's take a closer look at dispensing the medication just with the inhaler, then with a spacer attached, and finally, with a spacer and mask. To use a metered dose inhaler without a spacer attached, students should first exhale completely. It can be helpful to prompt the student to exhale by instructing them to blow out the candles. After exhaling, the mouthpiece of the inhaler should be inserted into the student's mouth with their lips forming a seal around it. The inhaler should then be depressed, and the student should inhale slowly, and then hold for a count of 10 seconds. Counting aloud can be an effective support during this step. Next, the student should exhale and resume breathing normally. If the asthma action or care plan calls for additional puffs, wait 1 minute and then repeat the steps for each prescribed puff. Using a metered dose inhaler with a spacer involves the exact same steps, but the inhaler is inserted into the end of the holding chamber. The student should first exhale completely, then insert the mouthpiece into their mouth with their lips forming a seal around it. The inhaler should be depressed and the student should slowly inhale. It's important to note that the spacer should not make any noise. If a whistling sound is heard, the student is inhaling too quickly and should be encouraged to inhale more slowly. After a full, slow inhale, the student should do their very best to hold their breath for 10 seconds, although for some, this will be very difficult. Encourage them to do their best by counting out loud. The student can then exhale and begin breathing normally, waiting 1 minute to repeat the steps if any additional puffs are indicated per their action or care plan. Finally, to use a metered dose inhaler with a spacer and a mask, the student should first exhale completely, then place the mask around their nose and mouth, forming a tight seal. Press down on the inhaler, and the student should inhale and exhale for a total of 10 seconds, counting out loud to ensure appropriate delivery of medication. The mask can then be removed, and if additional puffs are prescribed, they can be administered following the same steps, waiting 1 minute between puffs. After a student receives their rescue medication, what do you do next? Always refer back to their asthma action or care plan, which acts as a guide based on the student's symptoms. All 50 states and the District of Columbia have enacted state laws that allow students to self-carry and administer their asthma medication. The details of the laws differ, however, and school policies may also specify required protocols or procedures for doing so. Some states also have laws or regulations in place that allow schools to stock undesignated quick-relief asthma medication in case of emergency. We'll provide the opportunity to pause here so that you can review your school's policy around student self-carry and administration and find out if your school stocks undesignated quick-relief asthma medication. As school staff, we all play a vital role in supporting students with asthma. It's important to know which students of yours are at risk for an asthma emergency. To be familiar with their action plan and reference it when needed, to have access to quick-relief asthma medications and be prepared to help students administer them, to notify the school nurse or other school personnel in the event further assistance is necessary. And finally, it's critical to not hesitate in calling 911 if the student is not breathing, if they are unconscious. If their lips are turning blue, they are struggling to breathe or showing any signs of significant distress. This wraps up our school staff guide to asthma. You can pause here for any final questions or updates about asthma from your school health professional. In this part of the training, we will be covering allergies. The goal is for all school staff to be able to recognize symptoms of a serious allergic reaction and anaphylaxis. Know where to locate students' allergy action care plan and how to use it to appropriately support and care for the student, and to be ready and prepared to administer an epinephrine auto-injector using correct technique. An allergic reaction occurs when the body's natural defenses react excessively when exposed to a specific substance, treating it as an intruder and releasing chemicals to defend against it, creating an immune reaction. This overreaction can range from a mild response to severe and life-threatening. The most severe reaction is called anaphylaxis, a medical emergency that requires prompt treatment with an epinephrine auto-injector. Anaphylaxis occurs most often from various foods and insect stings. In the United States, food allergies affect 8% of all children, about 2 kids in every classroom. 9 foods or food groups account for most serious allergic reactions in the United States: milk, eggs, fish, shellfish, sesame, wheat, soy, peanuts, and tree nuts. While it is important to identify which students have documented food or insect sting allergies, it is important to note that 25% of allergic reactions that happen at school occur in kids with no previously known allergies, a statistic that emphasizes the importance of symptom recognition and appropriate response. Sadly, over a quarter of students with food allergies report being bullied over their potentially life-threatening condition. Compassion, support, and advocacy can help them feel safe and included. And, together, as school staff, we must collaborate to provide appropriate accommodations promoting inclusivity. Currently, there is no treatment to prevent food allergy reactions or anaphylaxis. Strict avoidance of the allergen is the only way to prevent a reaction. The most common route of experiencing an allergic reaction is through ingestion, which is why school policy should include strategies around preventing ingestion, including discouraging sharing of food, avoiding food as rewards, and planning ahead for field trips that include meals or snacks. Another route of experiencing an allergic reaction at school is through contact to a person, object, or surface, such as a door handle, desk, or arts and crafts supplies. This type of exposure should also be accounted for in school allergy policies through strategies like cleaning procedures and hand washing before and after eating. We'll provide this opportunity to pause in order to review your school's food and allergy policies. The first signs of an allergic reaction typically manifest within a few minutes to 2 hours following exposure. Life-threatening food allergies can show symptoms in various parts of the body, such as the mouth, throat, nose, eyes, ears, lungs, stomach, skin, heart, and brain. Severe symptoms may include breathing difficulties and a sudden drop in blood pressure, which could lead to shock and be fatal. Other symptoms may include tingling, swelling, or itching of the tongue, lips, or mouth, tightness of the throat, or a hoarse voice, a runny, itchy nose, red, swollen eyes, wheezing, nausea, stomach cramps, or vomiting and diarrhea, an itchy rash or hives, facial flushing, bluish tint to the skin, or paleness, a fast heartbeat or weak pulse, and an impending sense of doom. It's important to note every allergic reaction is different. Even if a student has only previously experienced mild reactions, the next reaction could result in anaphylaxis. Every student with a known allergy should have an allergy action plan. How do we use and interpret these plans? Let's break it down. The first part of every allergy action plan includes specific student information, including their name, specific allergies, and any special considerations, including severity. The second section of the action plan includes symptoms that may or may not be circled by the student's healthcare provider. Remember, every reaction is different, so it is important to be aware of all symptoms of an allergic reaction. As indicated on the action plan, for any severe symptoms, an epinephrine autoinjector should be administered as soon as possible. Likewise, if there are mild symptoms from more than one body part, for instance, the student has a few hives on their skin and is feeling nauseous, an epinephrine autoinjector should be administered as soon as possible. While one mild symptom may not require an epinephrine autoinjector, the action plan may provide guidance on what to do instead, but if you are unsure, it is recommended to never hesitate to administer epinephrine. You may know epinephrine by another name: adrenaline. Yep, epinephrine is the medication form of the hormone we've all felt coursing through our veins at one time or another. Epinephrine is the first-line, life-saving treatment for anaphylaxis, and the only treatment that can reverse symptoms. It comes in a variety of different autoinjectors, including EpiPen and EpiPen Jr., AUVQ, generic EpiPen, and generic Adrenaclick. The allergy action plan should have instructions for administering these autoinjectors, but it is important to be ready and prepared to act quickly should an allergic reaction requiring epinephrine occur. How to use an EpiPen or EpiPen Jr. First, you'll want to position the student laying down on their back with their knees bent. Take the epinephrine autoinjector out of the package or case and remove the blue safety cap. Hold the EpiPen in your fist with the orange tip pointed down. Think blue to the sky, orange to the thigh. The needle comes out of the orange end, so be careful not to place your thumb or hand over that end. Place the orange end against the side of the child's thigh, about halfway between the hip and knee. Swing and push the EpiPen into the outer thigh until it clicks. You can give the injection through clothes or on bare skin. Hold the autoinjector in place until all the medicine is injected, usually no more than 3 seconds. Count slowly out loud to ensure complete delivery of the epinephrine. Remove the EpiPen from the thigh and a protective shield will cover the needle. Put the injector back into its safety tube and give it to EMS when they arrive. If possible, massage the area after the injection. Here's an opportunity to pause for a demonstration and/or practice time with trainers. Next up, we'll review how to use an AUVQ. First, you'll want to position the student to lay down on their back with their knees bent. Pull the AUVQ out of its protective case, and it should start talking to you. Listen for the cues and proceed. Remove the red safety guard by pulling it firmly down. Place the black end of the AUVQ against the middle of the outer thigh, then push firmly until a click and hiss sound are heard, and hold in place for 2 seconds. You can give the injection through clothes or on bare skin. Pull the AUVQ straight back from the thigh to remove it. A protective shield will cover the needle, and you'll put the injector back into its case to give to EMS when they arrive. If possible, massage the area after the injection. Here's an opportunity to pause for a demonstration and/or practice time with trainers. Finally, how to use an Adrenaclick or generic EpiPen. First, you'll want to position the student to lay down on their back with their knees bent. Pull off the gray caps from both ends. The needle will come out of the red tip, so be careful not to place your hand or thumb over that end. Place the red tip against the side of the child's thigh, about halfway between the hip and knee. Press firmly into the child's outer thigh until it clicks. You can give the injection through clothes or on bare skin. Hold the autoinjector in place until all the medicine is injected, a total of 10 seconds. Count slowly out loud to ensure complete delivery of the epinephrine. Remove the auto-injector by pulling straight back from the thigh. If the needle is exposed, the dose was given. If not, repeat the above steps. Put the adrenoclick or generic back into its protective case and give it to EMS when they arrive. Gently massage the area after the injection. Here's another opportunity to pause for a demonstration and/or practice time with trainers. The beauty of epinephrine auto-injectors is that they allow a life-saving medication, epinephrine, to be quickly and correctly administered by just about anyone, no medical degree needed. But there is often hesitancy due to several factors, including uncertainty of whether symptoms warrant its use and fear of adverse reactions. But the fact is, you will not hurt a student by administering epinephrine. Remember, it's just adrenaline. Instead, delayed use of epinephrine in anaphylaxis is associated with an increased risk of hospitalization and poor outcomes. Therefore, if you are uncertain whether or not a reaction warrants epinephrine, use it right away, because epinephrine benefits far outweigh the risk that a dose may not have been necessary. Additionally, as many as 10 to 20% of individuals who are administered epinephrine will need more than one dose. A second dose auto-injector should be administered 5 to 15 minutes after the first dose if symptoms persist or worsen. What do you do after you administer epinephrine to a student experiencing an allergic reaction? Initiate the school's emergency response plan if it hasn't been already, and remain with the student until EMS arrives. Even if a student is feeling better after receiving epinephrine, they should remain laying down and must go to the emergency room for further evaluation and monitoring. All 50 states have laws providing students the right to self-carry and administer prescribed anaphylaxis medications. Additionally, almost all states have laws that allow or require anaphylaxis emergency preparedness plans that permit schools to stock emergency supplies of undesignated epinephrine auto-injectors. Now's a good time to pause in order to review your school's specific policy regarding self-carry, undesignated epinephrine, and where to find an auto-injector if you need it. As school staff, we all play a vital role in supporting students with allergies. It's important to know which students of yours have known allergies and are at risk for anaphylaxis. To be familiar with their action plan and reference it when needed. To reduce exposures to potential allergens within the school setting. To have access to epinephrine auto-injectors and be prepared to help administer them if needed. And finally, to know when and how to activate the school's emergency response system if a student has a severe allergic reaction. That requires epinephrine. This concludes our school staff guide to allergies. Pause here as needed for any final questions or updates about allergies from your school health professional. In this part of the training, we will be covering diabetes. The goal is for all school staff to be knowledgeable about diabetes and how it affects students, to recognize and respond to the signs and symptoms of low blood glucose, hypoglycemia, and high blood glucose, hyperglycemia, and finally, to know where to find the care plan for students with diabetes, and designated trained staff who can help with emergencies. There are 3 main types of diabetes: type 1, type 2, and gestational diabetes. For the purposes of this training, we will be focusing on type 1 diabetes. Type 1 diabetes occurs when the immune system targets and damages the beta cells in the pancreas, which are responsible for producing insulin. As a result, individuals with type 1 diabetes require daily insulin injections to compensate for the insufficient insulin production by the pancreas. In the United States, diabetes affects about 1 in 400 children, adolescents, and young adults under the age of 20. While the exact cause of type 1 diabetes is unknown, it is not caused by diet or lifestyle. There is no known cure for type 1 diabetes, but there are very effective treatments aimed at normalizing blood sugar levels. But this requires constant vigilance, both day and night. There are 3 potential emergencies that students with type 1 diabetes may experience at school: low blood sugar, very low blood sugar, and extremely high blood sugar. Blood glucose monitoring is a vital component of managing diabetes. In addition to routine monitoring, if a student experiences symptoms related to high or low blood sugar, they will also need to check their blood glucose levels. This is done one of two ways, either with a continuous glucose monitor or a blood glucose meter, or finger stick. A blood glucose meter is a small portable machine used to check blood glucose levels. A test strip is inserted into the meter. Then a small lancet is used to prick the side of the fingertip, and the drop of blood is placed on the test strip. The meter will then provide the blood glucose level on the digital display. A continuous glucose monitor, or CGM, is a system that automatically monitors glucose levels every 2 to 5 minutes, providing a constant picture of the glucose values. A sensor inserted under the skin every 7 to 14 days provides sensor glucose readings and sends the readings wirelessly to an inside pump, remote receiver, and/or phone app, where they can be viewed. Students who use a CGM also use a blood glucose meter in order to verify their CGM readings. Since more and more students are wearing continuous glucose monitors, let's take a closer look. CGM sensors track interstitial glucose, which is the glucose present in the fluid between cells, as opposed to blood glucose, which is measured using a glucose meter and a finger stick. Oftentimes, a mobile phone device is used to show the data and communicate potential problems because of the way they work. Sensor readings for glucose levels from a CGM can be delayed by up to as much as 20 minutes compared to blood glucose meter readings. The benefits of continuous glucose monitors are that they alarm when blood glucose levels are too high or too low, or when they are increasing or decreasing at a concerning rate. These alarms should never be ignored. They also provide the ability for remote monitoring. Data can be shared and viewed in real time, including alarms. Because of this, students will often carry a mobile smart device and will need access to the school's wireless network. If a blood glucose is measured to be low, this is called hypoglycemia. This is a serious condition that can manifest abruptly, necessitating immediate intervention. An individual who is hypoglycemic may have symptoms including feeling shaky, jittery, sweaty, having chills, irritability, confusion, blurred vision, headache, nausea, weakness, fatigue, dizziness, hunger, pale skin, pallor, fast heartbeat, and in severe cases, seizures. For most students, a blood glucose level of 70 milligrams per deciliter or less is considered hypoglycemia. Hypoglycemia can be caused by a variety of factors, including having too much insulin on board, missing or delaying meals or snacks, not eating enough, unexpected physical activity, illness, or, in some cases, especially in children, hypoglycemia can happen for no reason at all. It is not always preventable and poses the most dangerous risk to students with type 1 diabetes. So, what do you do to help a student who is experiencing low blood sugar or hypoglycemia? Every student should have a diabetes medical management plan that outlines appropriate steps. First, always notify the school nurse or a diabetes-trained school staff member. Do not send the student alone to the health office. If possible, check the student's blood sugar, per the guidelines in the diabetes medical management plan. When in doubt, always treat for hypoglycemia, as symptoms will progress quickly and become life-threatening if not treated promptly. If a student is experiencing mild to moderate hypoglycemia, they need a quick-acting sugar source to restore their levels to normal. These can include 3 to 4 glucose tablets, 4 ounces of juice, 6 ounces of a regular soda, or 3 teaspoons of glucose gel. The student's diabetes medical management plan should provide specific instructions for what quick-acting sugar source to provide and how much. It's important to have access to these fast-acting sugar sources in the classroom, or the student should have their own source based on their age and grade level. Then, wait 15 minutes, recheck the student's blood glucose level, and, if still low, repeat intake of the quick-acting sugar source. If indicated by the diabetes medical management plan, follow with a snack of carbohydrate and protein, and contact the student's parents or guardians. If a student is experiencing severe hypoglycemia, it is a medical emergency that requires immediate intervention. A student who is severely hypoglycemic may be unable or willing to swallow, potentially unconscious, or possibly having a seizure. Position the student on their side to keep them safe. Don't attempt to put anything in their mouth and remain with the student until the school nurse or another diabetes-trained school staff member arrives to give aid, and administer the life-saving medication, glucagon, if prescribed and ordered per the Diabetes Medical Management Plan. Activate EMS by calling 911, notify the student's parents or guardians, and remain with the student until emergency services arrive. What is glucagon? Glucagon is a naturally occurring hormone made by the pancreas to regulate blood sugar levels. A synthetic form of glucagon is used as a life-saving emergency medication to treat severe hypoglycemia in about 10 to 15 minutes. There are different types of glucagon, including newer auto-injectors and nasal sprays. We'll provide this opportunity to pause if your school nurse or health professional would like to include more information on glucagon, administration, and your school's specific policies and protocols. On the other blood glucose spectrum is hyperglycemia, or high blood sugar, which typically has a gradual onset and does not usually result in a medical emergency. For most students, a blood glucose level of more than 250 milligrams per deciliter or more is considered hyperglycemia, and symptoms can include increased thirst, blurry vision, frequent urination, nausea, dry mouth, changes in appetite, and fatigue. Causes of hyperglycemia include not administering a large enough dose of insulin, an insulin pump malfunction, decreased physical activity, illness or infection, an injury, or even stress. So, what do you do to help a student who is experiencing high blood sugar or hyperglycemia? Just like with hypoglycemia, steps to take should be outlined on the student's diabetes medical management plan. First, notify the school nurse or a diabetes-trained school staff member. If possible, help the student check their blood sugar. From there, the Diabetes Medical Management Plan provides instructions for treating the hyperglycemia. This may include having the student drink water or do some physical activity. While it should be the school nurse or a diabetes-trained school staff member that has been delegated helping to assist and treat the student with hyperglycemia, it is helpful for school staff to understand the process and how it may affect a student. Management of type 1 diabetes requires many supplies. Students should always have backup supplies for blood sugar monitoring, insulin delivery, and treatments for low blood sugars, and some may need to be stored in classrooms. As well, the Diabetes Medical Management Plan and glucagon should be stored in a location that is easily accessible during a severe blood sugar event. A handful of states allow schools to stock undesignated glucagon on school premises to be used in case of a hypoglycemic emergency. We'll provide this opportunity to pause in order to review your school's policies and procedures for stocking diabetic supplies and emergency medication. As school staff, we all play a vital role in supporting students with type 1 diabetes. It's important to know which students have type 1 diabetes and be familiar with their needs and where to find their diabetes medical management plan and supplies, including quick-acting sugar sources. For students with type 1 diabetes, hypoglycemia poses the most dangerous risk, and school staff should never leave a student experiencing hypoglycemic symptoms alone and never delay treatment for low blood sugar. Type 1 diabetes can be extremely unpredictable and affect kids very differently. Blood glucose meters may be different, healthy ranges of blood sugar may slightly vary, and there are various insulin delivery methods that may be used. Don't be afraid to ask questions in order to better understand and help. Support the student. Type 1 diabetes is a chronic condition that requires constant diligence, patience, and flexibility, but ultimately, kids with diabetes just want to fit in like every other student. Working together to ensure kids can manage their diabetes and still feel included is an important role for all school staff. This concludes our school staff guide to diabetes. Pause here, as needed, for any final questions or updates about diabetes from your school health professional. In the final part of this training, we will be covering seizures. The goal is for all school staff to be knowledgeable about and recognize the 3 different seizure types, to be prepared to administer seizure first aid, if and when necessary, to understand when a seizure is a medical emergency and how to respond, and finally, to know where to find the care plan for students with seizures and how you can help support them. A seizure occurs when there is a short burst of abnormal electrical activity in the brain. Seizures are categorized as either generalized or focal, depending on where the abnormal electrical activity occurs in the brain and the extent of brain involvement during the seizure. Seizures are the 3rd most prevalent school emergency. Epilepsy is a neurological condition that increases a person's risk of experiencing recurrent seizures. Sometimes epilepsy is referred to as a seizure disorder, and it affects 6 out of every 1,000 students in the United States. But not every individual that has a seizure has epilepsy. Seizures can also be caused by illness, low blood sugar, fever, prescription medication, or head injury. These are called provoked seizures. There are 2 main types of seizures. Generalized onset seizures, occasionally referred to as grand mal or tonic-clonic seizures, are what most people imagine when they think of seizures. These seizures involve both sides of the brain. Absent seizures are a type of generalized seizure that involve brief, sudden lapses in consciousness. The second main type are called focal onset seizures or partial seizures, which initially only affect one side of the brain but can spread to both sides, turning into a generalized seizure. Let's take a closer look at each type. First, generalized seizures and what they may look like. Oftentimes, a student may cry or groan and lose consciousness. They may experience stiffening of arms and legs, rhythmic jerking, shallow breathing, drooling, and their eyes may roll back in their head. A generalized seizure may last anywhere between a few seconds up to 3 minutes, and afterward, the student may be tired and confused. How can school staff help a student experiencing a generalized seizure? First, stay calm and start timing the seizure. How long the seizure lasts is extremely important and will be discussed more later. Reassure other students and, if possible, remove them from the area. All students with a known seizure disorder or history of seizures should have a seizure action plan that details what to do should a seizure occur, but seizure first aid should always be provided. First aid for a generalized seizure involves keeping the student safe and free from injury until the seizure resolves on its own. First, you want to gently ease the student to the ground if they appear to be falling. Next, remove anything near or around them that may cause injury. If a pillow or cushion is available, place it under their head, but be careful not to block their mouth or nose or inhibit their breathing in any way. Turn the student on their side to keep their airway open. And whatever you do, do not restrain the student and do not put anything in their mouth. If the seizure action plan indicates, the school nurse or delegated personnel should administer rescue medication and always remain with the student until they are alert. What are seizure rescue medications? Rescue medications are used to prevent emergencies by stopping seizures that otherwise last longer than normal, cluster, or fluctuate from the typical pattern. They can also be used to prevent breakthrough seizures during periods of high risk and emergencies. Most seizure action plans indicate rescue medication should be given after a seizure lasts a certain amount of time, which is why timing the seizure is a critical component to first response. There are 3 seizure rescue medications currently FDA approved. These should be administered, as prescribed and ordered, per the seizure action plan by the school nurse or other trained, delegated personnel. Most seizures, while scary to witness, are not medical emergencies, but it is important to know when a seizure is, in fact, an emergency and when to initiate the school's emergency response system. A seizure is considered an emergency when it's a generalized seizure lasting longer than 5 minutes, or per the seizure action plan. If there is no reported history of seizures, any breathing concerns during or after the seizure, repeated seizures, if the student is injured, has diabetes, or is pregnant, and any seizure that occurs in water. Now's a good time to pause if your school health professional has any specific school policies or protocols related to seizure first aid and action plans, before we dive into absence seizures and focal onset seizures. Next, we'll review absence seizures, a common but difficult to recognize type of generalized seizure. Absence seizures are often overlooked because they can easily be mistaken for daydreaming or lack of attention. Absence seizures comprise about 10% of all seizures in children and are the result of abnormal electrical activity in the brain, which causes a short-lived period of staring into space or blanking out. Absence seizures typically last less than 10 seconds, and while they may appear like the student is daydreaming, absence seizures cannot be interrupted. Generally, no first aid is needed for absence seizures. After an absence seizure, students can mostly resume their prior activity without assistance, but they may need a little reassurance or for instructions to be repeated. If a student appears to have an absence seizure and has no known seizure disorder, report these events to the school nurse or appropriate school health staff for further follow-up and care. The second main type of seizure is focal or focal onset. Unlike generalized seizures that affect both sides of the brain, focal seizures occur in specific parts of the brain. A student may experience an aura, or a feeling that a seizure is about to happen, before they have a focal seizure. Depending on the part of the brain where the seizure occurs, a focal seizure may cause changes in sensation, emotions, or thinking, cause the student to be very still or appear to be staring off, or cause repetitive or nonsensical movements like lip smacking, picking, or speech patterns. How can school staff help a student experiencing a focal seizure? Specific instructions should be found on a student's seizure action plan, which should be referred to and used as a guide. But care and support starts with staying calm and timing the seizure. Reassure other students and, if necessary, remove them from the area. Provide seizure first aid by keeping the student safe from injury, but do not restrain the student. If the seizure action plan indicates, the school nurse or delegated personnel should administer rescue medication and always remain with the student until they are alert. Lastly, it's important to be aware of psychogenic non-epileptic seizures, or PNES. These look like epileptic seizures but are not epileptic and instead are caused by psychological factors like stress and anxiety. Psychogenic non-epileptic seizures often manifest in generalized body convulsions, but do not generally warrant medical attention. Students with a history of PNES should have an individualized care plan that outlines support. But most often, if a student experiences an episode, it is best to monitor their safety. Avoid interacting with the student during the spell, and, only if needed, provide a brief 5 to 10 minute break to the student afterward. The main treatment for PNES involves diagnosing and treating the underlying psychiatric symptoms, and it is important to minimize the impact on daily functioning, including school. As school staff, we all play a vital role in supporting students with seizures. It's critical to know which students have a history of seizures and be familiar with their action plans. To always stay with a student having a seizure and remember to time it. To be prepared to administer seizure first aid, focusing on injury prevention. To recognize when a seizure is a medical emergency, and to be familiar with rescue medications and delegated personnel who can administer them if needed. This concludes our school staff guide to seizures and is the final section of this training. We at McGill School Nurse Supplies thank you for your time, attention, and all the care and support you give to your students. If you have additional questions, please ask your school nurse or other designated school health personnel. By working together, we can keep all students safe, healthy, and ready to learn.